Hello, friends. So, at the outset, I wish to thank my good friend Dr. Samvedam in having me for this fixed meeting. So, at the outset, I wish to say that I'm recording this talk from Indonesia. So as you see the backdrop, I'm sitting very close to Borobudur, which is one of the largest Buddhist temple in the world at this point of time. And as you see on the backdrop, there are 504 Buddha stupas. So I'm sitting very close to this monument in a very nice resort in Yogyakarta. So just few meters away, I have this beautiful monument, which is a marvel in its nature. So I'm recording this talk for my good friend. So the talk is very interesting. It's conflict management in ICU. So I wish to thank my another colleague, Dr. Pradeep, who is my team member who helped me develop this content. So on a holiday, I am delivering this talk, recording in this beautiful place. So the topics that I would be covering is a bit on the background, and we look into what is the origins of ICU conflict, and we look at what are the reasons for a conflict from family's perspective, and what are the different stages of conflict, and what do we understand by moral aporia and moral positions whenever there is a conflict. And the topic for today is what are the 10 steps that we need to keep in mind to resolve conflict in ICU and the take home message. So, when you look at most of the listeners here, intensely should know in an ICU, it's a very high intensity sort of environment, and people are in some sort of a duress at any point of time. And there is tremendous amount of stress in an ICU environment as a general rule. And amidst this high intensity, stressful sort of an atmosphere, we are expected to make rapid decisions. So that also adds on additional stress during this whole course of ICU. And to tag along with all this, we need to factor in the patient's preferences when we are making rapid decisions for the patient. And at the same time, there are various different opinions that come from within the ICU team members and the intra-ICU opinions. And most importantly, another important sort of an interfering factor is the perspectives of all the different specialists that may be involved in the care of the patient. So this is the typical sort of a milieu in which we work. So this high intensity, stressful environment where rapid decisions are to be made, keeping the preferences of the family and the ICU team and the interdisciplinary teams. All this leads to a proper sort of a recipe which can lead to the conflict. I think this is the typical sort of a recipe that we have or a very right pitch that we have in ICU for a conflict to arise. And when we talk about conflict, the conflict can be between various individuals within the ICU. It may be between the patient and the family members. Most importantly, between the family members and the ICU team. So when I say ICU team, for all the listeners, it is not only the doctors, it can be the nurses, it can be the paramedical staff, it can be physios, it can be dietitians, it can be nurses, so on and so forth. And the conflicts can be between the different teams that are involved in the care of the patients, as I said. So it is a very complex sort of a milieu in which we work, where conflict can arise from any of these sort of dimensions that are involved in the care. So what are the origins of ICU conflict? So we need to bear in mind. So for any ICU patient, there are three important aspects which we need to emphasize. One is the compassionate care that we give to the patient and the trust that the patients have in us whilst we're treating and the hope that we are creating for the patients. I think these three form an important tenets or pillars whenever we're caring for the patient in ICU. So why does conflict arise? Conflict arises when there is sort of a divergence between what the clinical situation is and what the clinical situation should have been. So when there is a divergence or dichotomy in this understanding of what the situation is and what it was meant to be, and there is failure of consensus that is drawn in narrowing this wedge within 48 hours is what is found to lead to conflict, which means if there is no proper communication that has happened to make family understand what the situation is and there is no sort of a divergence in their expectation, I think that is one important aspect how we can minimize the conflict. So this is a very important aspect to improve this understanding of the patients and to improve or to narrow down this divergence that exists between what is and what should be. there has to be three important components. So at the end of my talk, if you remember these three components, I think that would be the recipe for avoiding conflict, which is good quality, timely communication that needs to be happening with a shared decision making. So this is very important. So good quality communication with shared decision making, where whatever decision is being made has to be in concurrence and in consensus with the patient, with the family, and with all the team members that are involved in the care of the patients, keeping the values of the patient, preferences of the patients, and the goals that we have set for the patient. So this is, although there are a lot of things that I'm telling, but if you just remember these three pillars, is a very important recipe or important way how we can minimize the conflict, and obviously specific care for the clinical conditions in a committed, compassionate, empathetic way are the key aspects which can minimize the conflict. So good quality communication, shared decision making, keeping the values, preferences, and goals, and compassionate, empathetic care, addressing the specific clinical needs is what can minimize the conflicts. So, what are the reasons from the family perspective that conflict arises? From the family perspective, when family sees there is an unanticipated sort of change in the clinical condition or unanticipated event that has happened in the course of the illness that can lead to origins of the conflict, or the prognosis that is being explained to the family is misunderstood or misread by the family, or this is the most important aspect I'm sure most of the listeners would allude to. There is a discordance between the intensive care team and the other teams that are involved in the care and the family members, where there are different views or opinions given by the caregivers, is what is an important aspect we see day to day with regards to origins of the conflict. And as I mentioned, this is a very important aspect where there is lack of shared decision making, keeping the values, preferences, and goals. And this is something which possibly we do not have solutions, where family have unrealistic expectations in this day and age, because there is so much of amount that patients incur during the care of the patients. So there is element of unrealistic sort of an expectations, which is something which is difficult for us to address. And another, the last and important, and but not the least, is the ineffective communication that happens through the care of the patient. So these are some of the elements which are the salient elements as to the reasons why there is conflict from the family's perspective. Then there's something called decision paralysis. So the decision paralysis happens when the clinical uncertainty is looming around the family members. So when family is not clear as to what is the clinical course that their dear ones would be undergoing, or when the outcome prognosis is not established, or this again will be repetitive, that there is, this is a very important sort of a illustration that you need to keep in mind, that any disagreement that happens between the family member, the treating team, and all the other specialist doctors who are involved in the care is an important recipe for any conflict that arises, or the information given to the family is many a times can be confusing, because like we have an ICU team of 13 people, 13 doctors, and within our ICU team, many a times we would see on almost a daily basis that patient has misinterpreted the way things have been communicated by different team members. So they can get confused and it could be conflicting. I'm sure every listener here would allude to this, that within the ICU, the way it is communicated by the senior most consultant and by any of the team members will be hugely variable, and it will be perceived as very different and confusing by the family. So there are certain key aspects when we are communicating, how we minimize the sort of a recipe or the pitch for the conflict is having some of these body language. So sitting at the level of the patient whilst communicating and being open and not folding the hands and looking tensed, and leaning towards the patients while you're communicating, making a good eye contact with the family, and having a relaxed posture. All this you can remember by the acronym SOLAR. So these are some of the body languages or etiquette that one needs to have in mind when we're communicating. And these are all simple sort of a life skills that one can utilize to minimize the conflict. Then there is a spike approach where you make the patient sit whilst you're communicating in a comfortable position without a barrier or without any sort of a barrier between whom you're communicating to, and trying to understand the perceptions from the patient's perspective, and inviting them or to discuss and collaborate with regards to the diagnosis that one is working on and the type of prognosis that one is looking into, and whether the person whom you are communicating to has a good awareness and knowledge of illness and prognosis and providing emotional support at the same point of time, and what is the strategy and the future course of plan that one has in mind. So this is Pike's approach. So I'm sure many of the listeners would have understood this. So these are some of the behavioral etiquette and intensities should bear in mind to minimize the conflicts. So spikes and solar is something you can remember, easy to recall as to how we need to be communicating. So there are different stages of conflict. One is latent, where when you talk to the family, you know there is something cooking in their mind and something is not right. So that is the situation one should anticipate. There may be a possible situation where conflict is arise. Then there would be manifestation of this where there is an emergence phase, and then it escalates when it is not addressed in the latent phase or emergence phase. Then it gets escalated. Then you have a stalemate where there is a loss, there is a great dissonance of the trust between the treating teams and the patient, which is not a good thing to have. And after that, there has to be de-escalation, and then there is a dispute settlement, and then there is a post-conflict peace-building process that tends to happen. So these are the typical stages of conflict that has been described by various pundits. And there are interprofessional conflicts. This is very important, and it is shown that the interpersonal professional conflicts seem to arise and seems to prevail and is highest in certain life sustaining therapy or end of life sort of a situation, which I'm sure we all agree, because there may be a discordance or divergence in the views of the intensivists and other treating teams with regards to end of life or life sustaining therapies. And it is shown that in a situation where you're dealing with end of life or life sustaining, the clinical condition also becomes very dynamic, and there is degradation of the decision making process that tends to happen in this sort of a situation. And there can be distortion of the shared decision. So there is no shared decision making because there is a dichotomy or divergence or non-concurrence between the treating teams with regards to life sustaining therapy, where the goals are differential and it is not set, and there are discordant views within the family members, and there are disagreement within the family members or between the treating teams. All this leads to the conflicts. And as it is mentioned and referenced in the literature, the approach to end of life is complex and it is very highly variable. So there is something called Thomas Hillman model for conflict management. So where there are five sort of a dimensions in conflict management. One is competing, which is not the right way to end the conflict. Then there is avoidance. Avoidance is very bad in ICU to end the conflict. Then there is accommodating, also is considered very bad because accommodating is losing out to the the other person who is engaged in conflict and losing out yourself or surrendering, which is also, or sublimation or supplication, so which is also bad. So the best sort of a recipe for addressing the conflict or having solution for the conflict is compromising or collaborating. So please remember, this is a very important cartoon. You can keep it in mind. Two C's are what is important. Collaborating. Collaborating is the best, where there is some sort of a dialogue that happens and come out with a win-win situation. And before collaboration, it has to be some sort of a compromise where you let the ground down a little bit and then reach out and try to see for a workable solution. So compromising plus collaborating is the best way as to how we can resolve the conflict. So this is a very important sort of an aspect which I'll try to simplify. What is moral aporia? Moral aporia is where when there is a conflict, you have to let the ground down and and get empathetic to the person with whom you are engaged in conflict. So, but there may be this moral sense of feeling that you are losing out. So that is moral, where there is a dichotomy whether you are losing out on ethics in losing out to, and conceding to the conflict. So in the moral positions, the harm that can happen is there can be physical, psychological, which is easy, but there is a perceived harm where by losing out or where by reaching out to a compromise or collaborating, so one has a sense of feeling there is a violation of ethics or belief system that one is uh, so one is bound with, or the value system one is bound with. So that is moral aporia, where you are doing something, but it is against your principles or against the beliefs and values that you hold close to your heart. So there is a sense of perplexity where one questions oneself about whether uh, one is compromising on the ethical principles that he is guided by, and there is a situation of ambiguity or ambivalent. Ambivalent is where you are acting contrary to the beliefs and values that you uh, that, that you own or that you embrace or that you value. So that is moral aporia. So where you are doing something which is against your ethics just to resolve the conflict or end the conflict, you are letting your moral ground down and compromising on certain ethical framework that you are bound by is called moral aporia. This is something which tends to happen in conflict resolution, where right is not always equal to right and wrong is not always equal to wrong, is what you may have to reconcile to in moral aporia. What are the causes of conflict? There are three causes. There is substantiative causes where unexpected or undesired outcome has happened. And there is process problem where there is a differential policy, where there is discordant care given to individuals, which leads to conflict, or there is decision making error. So when I say differential policy or a discordant care, this can happen within the team and between the team and the family. And there is relational where there is opposing value based judgments that are happening, and there is communication failure. So these are some of the three broad causes. So the first one is easy: unexpected or undesired outcome leads to a conflict. So the differential policy in with regards to be it the type of care that is given to one group of patients vis-a-vis another group, which is evident as a discordant care, can lead to conflict, or whether there is a gross error in the decision making, which is quite intuitive that why conflict arises. And relational is where there is value-based judgment with regards to certain decisions, and communication failure. So these are some of the key causes of conflict that has been referenced and identified. So there is something called optimism bias, where the expectation is somewhere here, but the reality, as you see, is something entirely different. And which I mentioned, one of the important causes, unrealistic expectations. And this is something very hard when some of the families initially have unrealistic expectation to circumvent and counter that. Resolving the conflict can always be challenging. That is something one needs to bear in mind. So there is some sort of a matrix and or the dimensions or domains which are the usual causes of conflict always falls in one of these dimensions or domains, which is called conflict trigger matrix. So any conflict that arises within ICU will fall in one of these domains or dimensions. So I'll show you different dimensions. One is communications, the type of information given to the patient's emotion and empathy, family dynamics, the biases, which I said optimism bias, which I showed in a cartoon, health disparities, which is very much prevailing in a country like India, cultural differences, end of life disputes, goals, which we discussed, medical system distrust. So this is something where there has to be an institutional sort of a gear up to try to attain trust with the family members, and chronic illnesses where there is no reconciliation to caregiver disagreements and questionable policies. So this is sort of multiple sort of a basket from which there can be a stemming up of these conflicts. And most of the conflicts or all the conflicts fall in one of these baskets or dimensions or domains. So this is called trigger matrix. So then there is something called cycle of conflict, where when there is a miscommunication, the miscommunication can be multi-layered. And when miscommunication is percolating through all these layers, then there is whatever distrust that has developed becomes deeply entrenched. And the belief system that has been entrenched, which becomes very difficult and which leads to intractable sort of a conflict. There is a strong notion that whatever his belief is with regards to conflict is considered as right, and he or she considers the other party as being erroneous, and this becomes very difficult. So this becomes a vicious cycle, uh, which is uh, which is something which gets challenging to break it and try to attain solution when the miscommunication is happening at multiple levels or multiple layers. Then there is a deep entrenchment of this distrust, which becomes very hard to break it. So unresolved conflict. So this leads to a vicious conundrum of unresolved conflict, and this can lead to other ramifications like post-traumatic stress disorder, depression, or anxiety. So these are some of these deleterious effects of this vicious conundrum or cycle of conflict that tends to happen. So this is something one needs to recognize and bear in mind, that you want to eliminate or mitigate the conflict at an early stage and not allow it to percolate into multiple layers and allow it to get deeply entrenched. Then it becomes very difficult and it can start affecting the personnel who are dealing with. Then there's something called compassion fatigue. So this compassion fatigue is something very typical in ICU setting, where because it's a high intensity, highly stressful, very rapid decisions. So very often the doctors or the caregivers lose out on giving empathy to the patients and to the families. And this typically happens in very high volume ICU where there is rapid turnover, and you're dealing with multiple deaths at one point of time. You really sort of get into this apathetic feeling where you no longer feel that you need to be bothered about it, and you stop giving care with good compassion and putting yourself in that position of a patient. So we lose empathy. So this is a very dangerous situation to be in, and this needs to be recognized. And the triggers for this can be internal and external, and even this compassion fatigue can lead to intractable conflict, which leads to undesirable outcomes. So this is something one needs to always introspect and internalize and see whether someone is going into compassion fatigue. And this very much happens, even it happens to me sometimes when we have a very busy ICU with 3 deaths or 4 deaths happening. I think it's good that you get out of the system, because otherwise you're getting into that vicious cycle where you get irritable, and that can lead to cascading of the conflict. So this is something one needs to recognize oneself whether you are dealing. So we'll come to, so the first 20 minutes is all about the types of conflict, why the conflict arises, and what are the different sort of components or dimensions of conflict from the patient's perspective, from the family perspective, or from the doctor's perspective. Now we look into what are the techniques for ICU team members, which is the topic in next 10 minutes. Why do we need this? We need this to address the disruptive behavior or workplace violence. The first step, I'll go with 10 steps that is recognized and that is objectively sort of referenced, is try to recognize and prevent the emotions that are stemming up during the conflict. And these emotions can be someone being very angry, someone who is very frustrated, or someone who is very indignant. And all this leads to conflict, and this can lead to the harm to the individuals involved in the conflict, which can be real harm or which can be a perceived harm. Perceived harm also leads to conflict. And the early recognition of these moral emotions by the doctor helps in preventing the perpetuation or cascading of this violence. And it is important to identify the source of this moral injury. And this moral injury can be internal or external moral. So early recognition of the emotions that may be stemming up, which leads to conflict, is very important as a first step. So first step is recognition of the emotional aspects which can potentially lead to conflict is becomes very important. So what is the second step? Second step is prevention and de-escalation. So this is a very important slide. So this every day in ICU we deal with this second step, which is trying to delineate positions and interests. This is very, very important, which I deal with in my ICU every day. So delineating positions and interests. What is position? Position is externally articulated preferences. So I'll give you an example where someone is deteriorating, and then there is a huge furor in the family that you are not treating the patient, nothing is communicated. This I'm sure every listener will allude to me, that they'll say nothing is explained to me. Now you are telling me that patient is deteriorating, dying, and he needs dialysis, and we are very unhappy. So these are externally articulated preferences, and family members may be making these statements, which is binary. Binary means it is in opposition. So they are basically making certain statements which are not true. But the interest, very often, when you dwell into the interest, the stated statements not necessarily true, because you may be explaining every day about the progress, but they're telling this. But the interests are internally held values of concept. Maybe so. What the example is, the interest may be financial. Many a times, because they're not able, suddenly they get a bill of some amount, and they're unable to bear this financial burden, and they are masking this with the externally articulated preference, because the interest is finance, but the positions they're taking is blaming on the system. So this is called, this is trying to delineate position and interest. because the internally held values or concerns is underlying the statements that they are making as to why I want it. So they are making a claim, but the main reason may be something else. So that is delineating positions and interests. And trying to find out interest is very important, because when they are making certain positions or claims which is untrue, you are unable to mitigate this. But once you know the interest, which may be financial in the example I gave, then it becomes easier for you to break the conflict and try to get them on a common ground where you can have a compromise. So this is a when the interest is known, then it becomes some sort of a shared responsibility to mitigate the conflict, where you can get into a common ground to attain this compromise. So this is a very important slide. Please remember this, that any conflict that arises, the statement being made is uh, is an outward thing, but underlying thing or the undercurrent, there may be an internally held other concern which needs to be explored, and solutions can be gained by understanding what is that interest with which they are behaving that way. So the analogy, the typical analogy which simplifies your understanding, is a tree. So the position is the tree, the leaves and all the other things, but the interests are the roots. So digging into the roots you will be able to know what is the exact reason why the person is behaving that way, into creating a conflict. But digging into this to have a win-win situation, one needs a lot of patience and time and commitment from the clinicians, and should be able to understand the current and pre-existing events and influences to get into the interest. Otherwise, many times it may not be very easy. So that is the second step, trying to delineate between the positions and interests. The third step is very active listening. So this is a very important aspect. Many of you would have heard from many pundits. Rather than speaking during conflict time, it is very important just listen out to someone who is engaged in the conflict as to what they're saying, and it's important to repeat the words like it sounds like from what I understand. So after he says, um, after he or she who is engaged in conflict says something, it is good that you re-emphasize saying, from what I understand, this is what you're trying to say, rather than trying to counter what they are saying. The fourth step is very important, to express your inquisitiveness, to express your desire to know more about what the reason is that they're behaving that way, to probe individual concerns. And again, in the fourth step, try to understand what their true interests are as to why they're behaving that way. So very often this I use it, and when you say uh, when you try to dig in little more, you will get to know as to what is the exact reason why they're behaving that way. Okay? So by using the words, tell me more about, and what are you hopeful for? What are you looking at uh, for the solution with regards to this particular situation? So something like that I ask. So what do you think we should be doing to help you out? So these are the statements that I make, which is important to understand. Then they will say, so my problem is I'm not able to bear this expenses, or my problem is I had problem with this doctor, the way it is coming. So at least you'll know what the solution is. So the fifth step is empathy, which is very important, putting yourself in their position and acknowledging their position, validating their position, and respecting their position is called empathy. Is all about putting yourself in the patient's shoes or the family member who is involved in the conflict, putting yourself in their shoes and trying to think from their perspective. So, and using the words, I can imagine, so this has been difficult for you, and I'm so sorry, things have been so challenging. So, why you are saying this is putting yourself in their position and trying to imagine how one would be feeling, is all empathy about. The sixth step is trying to acknowledge different perspectives as to from the thought process, so which is plurality of moral emotions, which helps you in trying to get into a decision to resolve the conflict. So acknowledging different perspectives of a different family members who are involved in the conflict helps you to come with a solution. So like asking questions as you've seen it, I imagine from your point of view, because if there are three, four people engaged in conflict, so you can delineate and try to say that as I see from this person's point of view, this is what I get to gather. Something like that is very important, and it's important to say it's okay for us to disagree about the best option for you or your loved one. So it is basically acknowledging different perspectives that may be stemming up when you are engaged in the conversation in the conflict. The seventh step, which is very important, which I use it very often, is identifying the emotions. I always tell, I want to know what is running in your mind as I see you. You are the situation you are in. I find you are very sad, or I find you are in a very devastated position. So it is important to name that emotion. So identifying, naming, and respecting that emotion. So he may be feeling angry, he may be feeling frustrated, he may be feeling indignant, he may be feeling devastated, terrible. So I use the words, I see that you are feeling terrible and I empathize with you, something of that order. So I sense you are terrible. Is that correct? Many people in your situation would feel terrible. Is that how you feel? I imagine if I were you in your situation, I would feel terrible as well. Are you feeling that way? So putting yourself, using that word, so using the word for that emotion that you are feeling very sad, or you are feeling devastated, you are feeling terrible, you are feeling very angry, you are feeling frustrated, you are feeling apprehensive. Use some word for the emotions and tell, I would also feel the same feeling. Is the seventh step, using that own emotion. So eighth step is so abandoning the moral high ground. So when you are engaged in resolving the conflict, we cannot stick to our high moral ground. So we have to come down the moral high ground and don't stick to your point of view, which may be correct. So never keep repeating that what you did was the right thing. And this is a very difficult thing. It is very difficult for all of us here, including me, letting go of our ego. I think we need to be spiritually exalted to let go of our ego. And so I think this becomes very difficult, but somewhere we have to reaffirm to ourselves that we have to let go of our ego, especially when we're dealing with a conflict situation. So ninth step is righting the wrong, it may be perceived or real. So basically expressing regret. So here you take one step backwards and put yourself in a regretful position. This is also a very difficult. So this comes one step after ego. Ego is where you just don't stick to your point of view, saying that what you did was right. So that is the eighth step. But the ninth step is going one step backwards and saying, I'm sorry. So I think this is also very difficult. I'm sorry that such a thing has happened. I wish things were different. So the eighth and ninth steps are very difficult. Letting go of your ego, letting go of our moral high ground. And ninth step is taking one step backwards and expressing the regret that this should not have happened, or this situation should not have risen where we are engaged in conflict. I think that also becomes very difficult. The 10th step is very easy, where you get into the mediation process, where you have a person who is mediating between the two teams, where there is some sort of a good dialogue that is that is sort of engaged in to get them to truce, and having some elements of education to get the moral sort of a aporia inculcated into each parties to resolve the conflict and finding an amicable solution. So the 10th step is the result of a successful eighth and ninth step. So eighth and ninth step, I believe, are very important. Letting down your moral high ground and retracting a bit and righting the wrong where you express your regret. So which is sort of a compromise that you get into. And then after compromise, the 10th step would be collaborating. So where you are trying to educate and transform and be transformative in your approach. So, so the whole thing is all about mediation. You need a lot of training. So the key aspect is recognizing, preventing, and de-escalation. So the take-home message, so I've just taken 1 minute more. So the conflict within ICU between the patient, family, ICU team, and the other teams is a multifactorial process, and it is multidimensional. So this statement which I'm making is extremely important. So the important recipe for the conflict is good quality communication, shared decision making, keeping the patients and families' values in mind, preferences in mind, and goals in mind is very, very important. And compassionate, empathetic, committed care, clinical care, addressing the specific clinical needs. These three form an important pillar as to how we can avoid the conflict. And the best solution for conflict is a combination of a compromise and collaboration with the person you are engaged in conflict is the best solution. And remember and reaffirm the 10 steps that I mentioned. Eighth and ninth are important, followed by the 10th, which is collaboration and compromising, and mediation and regular training on conflict resolution. Recognizing becomes an important step. Once you recognize, trying to take preventative steps very early on and de-escalation are the important tools for conflict resolution. So thank you, and all. I end with this beautiful quote. You can't change what's going on around you until you start changing what's going on within you. And this applies very much to conflict resolution. So thank you one and all, and goodbye from Borobudur, Indonesia. So it's a great place. So any of you have an opportunity, visit this place because many come to Indonesia and only go to Bali. But there are great sites like Borobudur, and tomorrow I'm going to Prambanan, which is the largest Hindu temple after Angkor Wat in the Southeast Asia. So thank you. Bye from Indonesia. Thank you, Bandhu.